I will talk about colorectal cancer, some data from Iraq. I don't know if it is now, you can see it.
ظاهرة يا دكتورة نوال، تفضلي.
I'm sure all of you know that colorectal cancer is the commonest malignancy in the GIT, and it is the fourth leading reason behind cancer-associated death in the world. It usually begins with the non-cancerous colonic polyps, which might grow gradually for 10 to 20 years before becoming cancerous. I will not pass this statement quickly, because this 10 years is very important, 10 to 20 years. So when you discover a polyp in colonoscopy, please remove it, because your crime will not be discovered, because the tumor will appear after 10 to 20 years. So it is a hidden crime not to remove the adenomatous polyp in the colon, because it will turn to be malignant after 10 to 20 years. Why we might have colorectal cancer. The first to come is the genetic and hereditary factors. There is a battle between activation of the tumor-promoting gene and the inactivation of tumor suppressor genes. Which one will win? When the activation tumor gene will win the battle, there will be a cancer. In addition to genetic, there might be environmental factors. One of them is the diet. By now, it's the well-known factor. There is some food that can be considered as carcinogenic food, like people who eat a lot of red meat or saturated animal fat, and it is low in fiber, and the vegetables and the fruits also low in their food. Those are environmental factors that can be a risk factor for colorectal cancer. The disease of this age, of this years, is the obesity, the smoking, and alcohol, which is increasing all over the world. Don't forget the long-standing inflammatory bowel disease as a risk for colorectal cancer. What about the epidemiology of colorectal cancer? It was used to be a disease of the elderly in the Western world. Most of them around the age of 70 at that time. But now it is changing, as in different parts of the world. The incidence rate of colorectal cancer has increased 3% yearly for younger than 50 years, which is known as early onset colorectal cancer, which is by now one of the most important issues in the colorectal cancer is the young age. This rise is more of the distal colon and rectum. This can give a point that sigmoidoscopy is an important tool to diagnose. Let us begin with sigmoidoscopy, because the most common site is the distal colon and the rectum. When I come across the data for the epidemiology, the Arab world considered to be low in incidence. Several mechanisms have been adopted to explain the significant low incidence of colorectal cancer in the Arab countries. They think that the fasting, whether in Ramadan or outside Ramadan, food full of recipe filled with spices, مختلف أنواع البهارات والكركم, significant lower rates of smoking and alcohol drinking. This is in relatively to the West countries. And also the genetic predisposition, which is the good thing that we inherited. What about in Iraq specifically? Iraq has a high population growth rate, with a population number of around 40 million in 2000, and by now more than 40 million, with a male to female ratio 1.02 to 1. In spite of all the wars that we passed through, and the male was the one who is in the front, but still the male in Iraq more a little bit than the female in our society. There is Iraqi National Cancer Registry database. which was published by those authors. It is sponsored by the Ministry of Health. The Iraq started this cancer registration in 1974, and that's good because it considers to be early, and adopted the Cancer Register 3 program. The Can Register 3 in 2000 was updated in 2019 to Cancer Register 5, which was developed by the International Agency for Research on Cancer. This is the center of this data in Lyon, France. We follow them. Here, the top 10 cancers in Iraq, the incidence rate per 100,000 population. It was taken in 2019. Colorectal cancer comes the 4th in the top 10 cancers in Iraq. And this Iraqi National Cancer Registry database studied a total of 20,880 cases of colorectal cancer with an age range from 14 to 80 years from all the 18 Iraqi governorates that are registered at the INCR that I mentioned over the years from 2000 to 2019. Actually, in the literature, they mentioned there were only, I cancel the word only because 101 colorectal cancer cases in the age group 14 to 19 years is not that only. It is a big number because this age is scary, that age 14, 15, 16, and 19 is very young, that you cannot consider them a risk for colorectal cancer. They might present with bleeding per rectum and a lot of hemorrhoidectomy done to them because of the age only. The colorectal cancer increased dramatically in Iraq from 2.28 in 2000 to 6.18 per 100,000 population in 2019. Look to the upsurge of this incidence. It is 171%, very high increase in the colorectal cancer in Iraq. Why was that? Since 2003, after the war that you know about, Iraqis changed in all life aspects toward the Western lifestyle. For example, increased alcohol intake, increased smoking, especially shisha smoking and all other types of smoking. In addition, there may be possible effects of environmental and chemical hazards of the Iraqi-Iranian war and the Gulf War that remain to be seen. So both factors attributed to this high increase in the incidence of colorectal cancer in Iraq. Actually, it's a horrible increase in the incidence, yet we can see the neighboring countries to Iraq, like Turkey, Iran, Saudi Arabia, and Jordan, they have a relatively higher incidence rate of 24, 12, 10, and 9 per 100,000 population, respectively, according to recent statistics. All these incidents higher than what is in Iraq, even after that increase in the incidence in Iraq. Still, the neighboring countries higher than us. This Iraqi incidence considered still relatively optimistic, though it's optimistic according to the neighboring, but yet the overall picture is gloomy, as it has been growing progressively over the last 20 years. When we will do another study like this one, that one, which is very large study, we might find that by now we are more than the other countries in their in our incidence in colorectal cancer. This progressive increase in colorectal cancer incidence and fatality should be addressed by health authorities to design a screening program and increase public awareness. Actually, in the early this century, there was a committee in the Ministry of Health considering this issue and start to do, trying to do screening for public screening. And by now, there is a fellowship, بالحقيقة زمالة, there is a fellowship تابعة للبورد العربي اسمها Early Detection of Cancer, all the cancers. It is a 2-year study, breast cancer, colorectal cancer. Hopefully, this fellowship will help our community for early detection of this cancer. How we can screen this cancer? Currently, 3 types of stool tests are approved by the U.S. Food and Drug Administration, FDA, to screen for colorectal cancer. The old one, Goya fecal occult blood test, by now it's not used because of the false positive test of it. And there is a precaution before doing this test. The other test, which is by now considered the screening tool in a lot of countries. I got an Iraqi patient from, I think, Sweden. She told me they do only the fecal immune chemical test to screen, no colonoscopy in that country. So a lot of countries use this fecal immune chemical test for screening colorectal cancer. The abbreviation FIT, or I, from immune histochemical fecal occult blood test. So by now, this one is the most valuable test. The other one, virtual colonoscopy, which is CT colonography. Actually, this CT is very nice pictures, but it is not considered as a tool for screening because of radiation cost, and so it is not used, but I like to mention it. The more sophisticated one is the multi-targeted stool DNA testing, not like FIT DNA. Also, this is only, I think, in some research centers. The most widely should be used is for screening is the colonoscopy and sigmoidoscopy. In USA, they say anyone over age of 50, male or female, should get a colonoscopy every 10 years. Every 10 years, colonoscopy should be done in asymptomatic people. By now, this age 50 is considered old. So they start to do the screening at age of 45. I know by now from our mentor Makki Hamadi that in Emirat they also start the screening at age of 45. Never forget that there is a special situation for colonoscopy, which the age is not considerable, need to be considered, like a patient with inflammatory bowel disease. And most of you know how to screen for colorectal cancer in those patients, or patient had family history of colonic adenoma or colonic cancer, or there's family history of FAB or Lynch or acromegaly. A lot of precancerous or diseases risk for colorectal cancer should be considered when you want to consider the screening. Well, as I mentioned, the American Cancer Society changed its screening recommendation in 2018 from the age of 50 to 45 years of at average risk, owing to the upsurge in incidence in young adults. As I mentioned, the young adults all over the world, not only in special countries, and so in America and Emirates, the age of screening is 45 years. In Iraq, up till now, we have no screening program in Iraq whatsoever. A lot of trials from my colleague trying to do, even at least for personal efforts, like FIT, because it is by now the FIT tool for FIT is available. So we should consider this screening not necessarily to be addressed by the Ministry of Health. For example, if I know the patient has irritable bowel or even reflux or whatsoever, and I want to do, for example, upper endoscopy, or he doesn't need any endoscopy, but I will inform him, because of your age is above 45, you are on need of colonoscopy. Please don't forget that, to inform, at least for awareness, tell your patient that you are on need of colonoscopy after the age of 45 or even 50. Fortunately, I found a lot of Iraqi studies on colorectal polyp and colorectal cancer. As I mentioned earlier, colorectal polyp detection rate is very important. مقياس الاندوسكوبيست ايش قد هو شاطر، هو يعتمد على polyp detection rate. لذلك we can see that even the time of withdrawal they increase it all to increase the polyp detection rate. And as I mentioned also earlier, after 10 years, 8 or 10 or 20 years, this polyp will be cancer. So there is 2 studies that I can find it carried out in GIT teaching hospital in Baghdad. One of them, I am the one who is participate in it for the polyp detection during 2 years from 1998 to 2000, 64 patients had polyp out of 1,607 colonoscopy. So it was 4%. There is another study done in 2015 to 2016. The polyp detection rate was in 128 out of 764. It was 16.7. It is much larger than the first one. Maybe the number is less or the facility is better, whether the endoscopy is better, the experience is better, so the polyp detection rate was higher, or because the ongoing year and increasing cancer is the cause. Most common histological type was adenomatous polyp, unfortunately, which is the most precancerous one. This result was similar to a study done in Karbala. I found 2 studies from Karbala. I communicate with Dr. Hadi about it. He is the one who is doing this. During the period from 2012 to 2016, a total of 1,380 patient colonic polyps were found in 16, which is equal to that study. And the second one, in 23 and 24, total colonoscopy were carried out for 1,467 patients, and the colorectal polyp was identified in 9.9%. So it is a considerable number, even if it is between 9 and 16. What about, I talked about polyp. What about colorectal cancer in Iraq? We should never forget our mentor, our professor, our pioneer, Zuhair al-Bahrani. I think he is the one who has the largest study and registry about colorectal cancer. He had a large retrospective study in colorectal cancer involving 511 patients registered over 30 years. Look, we cannot do this study. 30 years he is following his patient. From 1965 to 1994 showed a younger mean age of 50 years. From that area, the age start to be younger. Rahma ala ruha. I published one of the studies, which is a clinical study of a newly diagnosed colorectal cancer over 2 years in GIT center in Iraq. This study 63 cases with newly diagnosed colorectal cancer, and there were almost equal between male and female, the ratio 1:1. And we can see that the youngest was 27 years old, and thanks not that age 14, and the peak in between 60 to 70 years age. And you know the screening should be at least 10 years before the diagnosis, before the peak of incidence of colorectal cancer. In this study, the anatomical subside was almost 2/3 in rectosigmoid region as the other countries. And all patients less than 40 years. So this makes us think that sigmoidoscopy is very valid and very important. Though in Iraq, it doesn't matter whether to do sigmoidoscopy or colonoscopy because it's the same preparation, the same booking, the same price almost. So it doesn't different a lot. So most of our patients changed from sigmoidoscopy to colonoscopy. The bleeding per rectum, also as others, was the most common symptoms, occurred in 2/3 of the patient, while the least common was weight loss and alternating bowel habits. Bleeding per rectum in Iraq actually is a big problem because most of the patient went to a surgeon, and we have a lot of patients, they did a lot of hemorrhoidectomy and no colonoscopy done to them, and they turned to be colorectal cancer. Here's the duration before referral for colonoscopy. The shortest duration was 10 days, and that's because of bleeding per rectum. As the surgeon do hemorrhoidectomy, but luckily the patient, when they see blood and they have bleeding per rectum, they go for sigmoidoscopy or for colonoscopy earlier than the other symptoms. The mean duration of symptoms before referral was 7 months, a little bit accepted, but there is a patient after 6 years that he did the colonoscopy. It was polyp, tend to be colorectal cancer. We will shift the presentation. We will keep talking about colorectal cancer, but I want to say, are all colonic masses cancer? We should put a light for that. I had a lot of cases actually, which is solitary rectal ulcer. It looks like tumor, very difficult to differentiate. Keep taking biopsy. It is non-specific, a lot of piecemeal polypectomy, and then it was solitary rectal cancer. I keep telling the patient, who pray for you? Diverticulitis. I have 3 cases, obstructed lumen, and there is a mass, and I cannot pass the scope, but it tends to be beyond that mass. There's a lot of diverticuli, and this mass is related to the diverticuli, and there is a lot of debate whether the diverticulitis is a risk factor or it is just associated, but I am by now talking only about diverticulitis. This is not a tumor. The specimen in surgery was only diverticulitis. Crohn's disease. Actually, I have 3 cases. They are not, Crohn's tend to be cancer. As you all know, that Crohn's is a risk factor for colorectal cancer. But this case is isolated mass. All the colon and the ileum were normal. After surgery, this mass is only Crohn's. There is no malignancy. So sometimes be optimistic, it might not be a cancer. And I give the excuse to the oncologist not to give chemotherapy unless they have a histopathological report of having cancer. This is the GIST, and I think all the endoscopists will, when see it before the biopsy, we can tell this is a GIST tumor. Primary colorectal lymphoma, I have only 1 case for that. Carcinoid tumor, I have a few cases, most of them rectal. One of them is a famous singer, and it was more than 20 years when I diagnosed him, and there is no follow-up, and I keep watching him singing up till now. So it was an early tumor. I never see a case of schwannoma of the colon. So take-home messages. First of all, I would like to highlight the screening. As in Iraq, immunological fecal occult blood testing can be done, and don't forget, and you can ask the lab beside you to do it. Colonoscopy performed at central hospitals. By now, it is available in almost all governorates in Iraq, and it can be under sedation. So by now, it is accepted by the patient more than before. They accept to do it under sedation. I talked about sigmoidoscopy, molecular genetic analysis. So understanding colorectal cancer incidence and the clinical features of them is vital to design effective screening program with public awareness. Public awareness is very mandatory. So keep telling your patient whatever he comes for colonoscopy. Colon cancer is preventable, treatable, and beatable. We can cancel it, you can erase it. So I keep telling the patient, don't be panicked. By now, the colorectal cancer with the new surgery, even laparoscopic, with the deep X-ray therapy, with chemotherapy, it has a very good prognosis, even if it is with secondaries. It's important to educate yourself. I will ask you all to raise your hand and to tell me who had subjected to colonoscopy, especially if he is older than or she is older than 45 years, and your patient, especially if this age. So please raise your hand and see who did the subjected to colonoscopy, because I was very not surprised. Actually, I can imagine when I asked in one of the meetings, actually twice, one in Jordan and one in Slemania, who had the colonoscopy done for him. Very little number raised their hand, and they are a doctor. So how you can convince your patient if you yourself not convinced to do it? So please, if you are above age of 45 and you are not doing colonoscopy up till now, so please do it for try to get it and do colonoscopy. So build up your knowledge, build up the screening tool for a very important prevented colorectal cancer. And thank you very much.
Thank you very much.